Good afternoon and welcome to the American Heart Association's Transthyretin Amyloid Cardiomyopathy, ATTR-CM webinar series. We are thrilled to have you with us today for our third session in the series, Cardiomyopathy in Focus, Recognizing and Managing Cardiac Amyloidosis. It is a pleasure to welcome you today as we deep dive into diagnostics, treatment, and the multidisciplinary care model for this complex and often under-recognized condition. Before we begin, a few quick housekeeping items to note. Today's webinar is being recorded. All participants have been muted upon entry to reduce background noise. We encourage an open conversational discussion, so please engage and share your thoughts. Time has been dedicated at the end of today's webinar for a panel discussion and Q&A. Please feel free to submit your questions via the chat at any time throughout the didactic sessions. We will address as many questions as time allows during the dedicated Q&A portion at the end of today's webinar. A recording of today's session will be available in the coming weeks as an enduring educational resource on www.heart.org. My name is Devin Marie Keating, and I serve as a Director of Operations in Clinical Studies here at the American Heart Association, overseeing our work in cardiac amyloidosis. I would like to take a moment to extend a sincere and special thank you to Intellia Therapeutics for supporting the American Heart Association in our efforts to impact and improve transthyretin amyloid cardiomyopathy awareness and education. The American Heart Association's ATTR-CM educational webinar series was developed to advance awareness, early diagnosis, and equitable care for transthyretin amyloid cardiomyopathy through expert-led sessions that educate, engage, and equip multidisciplinary teams with the knowledge and resources needed to improve patient outcomes. It is now my extreme pleasure to introduce today's expert speakers. Our first speaker, Dr. Jan Griffin, is an Associate Professor of Medicine and Director of the MUSC Amyloidosis Center at the Medical University of South Carolina. Dr. Griffin is a leader in diagnosis and management of amyloidosis with extensive experience in both AL and ATTR disease and a strong focus on multidisciplinary care. Dr. Griffin will open our session by framing cardiac amyloidosis, highlighting its pathophysiology, systemic nature, and the importance of early recognition, including key cardiac and extracardiac features that should raise clinical suspicion. Our next speaker is Dr. Janice Peretti, Associate Professor of Medicine and Medical Lead for Cardiac Amyloidosis at the Hospital of the University of Pennsylvania. Dr. Peretti specializes in the evaluation and management of cardiac amyloidosis and is deeply involved in advancing diagnostic pathways and treatment strategies. Dr. Peretti will build on this foundation by discussing practical approaches to identifying cardiac amyloidosis in clinical practice, including multimodal imaging, laboratory evaluation, and current as well as emerging therapies, with a focus on optimizing patient outcomes. And our third and final speaker, Dr. Eugene Brailovsky, Assistant Professor of Medicine at New York Presbyterian Columbia University Irving Medical Center. Dr. Brailovsky is an expert in advanced heart failure and cardiac amyloidosis with a focus on comprehensive patient-centered care. Dr. Brailovsky will conclude today's session by highlighting the critical role of multidisciplinary collaboration in managing cardiac amyloidosis, offering real-world insights into coordinating care across specialties and improving outcomes for patients with this complex multi-system disease. We are honored and very grateful to have you all with us today. Today's webinar will provide a practical overview of cardiac amyloidosis within the spectrum of cardiomyopathy, focusing on early recognition, key diagnostic strategies, and current and emerging treatments. It will also highlight the importance of multidisciplinary care in improving outcomes with real-world insights into managing both cardiac and systemic manifestations, including AL amyloidosis and ATTR amyloidosis. Please note, the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. These materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA or ASA. The American Heart Association does not endorse any product or device. Disclosures for Dr. Griffin, Dr. Peretti, and Dr. Brolowski have been listed here as well. With that said, I would like to turn the mic over to Dr. Jan Griffin, who will help kick things off today with cardiac amyloidosis, understanding the heart and beyond. Thank you again, Dr. Griffin.
Thank you, and good afternoon, and thank you for inviting me to speak today. So amyloidosis, there are over 40 known amyloidogenic proteins which have been detected thus far. Cardiac amyloidosis typically arises from either transthyretin, also known as TTR, or light chain, also known as AL amyloid deposition. And this is in over 95% of cases. You can see here on the right the multi-system nature of this disease. It can affect anything, the heart, the nerves, musculoskeletal manifestations, GI, and neurologic manifestations, among others. Deposition in the myocardium leads to a restrictive cardiomyopathy, and deposition in the nerves to a sensory, motor, and autonomic neuropathy. My slides are not, oh, I'm so sorry. It was not detecting my slide movement. There we go. So on this slide, you see the biology of transthyretin amyloidosis. So amyloid formation occurs when a protein loses, or if it fails to acquire, its physiological functional fold. A number of factors can trigger this, such as abnormal proteolysis, point mutations, and post-translational modifications such as phosphorylation, glycation, and oxidation. The misfolded protein or peptide then assembles with similar proteins to form oligomers, which circulate in the blood, and then they deposit as highly ordered fibrils in the interstitial space or target organs. Here we see TTR, which is predominantly made in the liver, with small amounts also being formed in the retinal epithelium and the choroid plexus. TTR is a homotetramer, and due to the process of aging or due to an inherited mutation, this TTR homotetramer can become unstable and then dissociates into monomers and oligomers, which then misfold and aggregate to form amyloid fibrils, which deposit in the various organs of the body. This line outlines light chain amyloidosis pathophysiology. Light chain amyloid is a little bit different. It occurs from the overgrowth of clonal plasma cells in the bone marrow. The monoclonal protein is usually also found in the serum and urine. It can deposit anywhere, as you can see, in the nerves, kidney, GI, liver, various tissues, and in cardiac involvement occurs in 60 to 70% of cases and portends a worse prognosis for these patients. Here we see the major causes of cardiac amyloid, as I've just outlined, over 95% being caused by light chain or TTR deposition. And you can see here that the age of diagnosis for light chain disease is in the 40s to 80s, but it can occur more at a younger age. In variant disease, the age of presentation really depends on the variant that's involved, with early onset V50M occurring as young as the 20s in endemic areas in Portugal. Sex distribution, male predominance, particularly in TTR cardiac amyloid, both wild type and variant. You can see here that there is an autosomal dominant inheritance in variant TTR cardiac amyloid. Multi-system clinical manifestations are wide and broad in each of the types of cardiac amyloidosis. And prognosis really is quite different, though, between disease types. So in AL amyloidosis, the prognosis can be very poor, particularly if there is cardiac involvement, with a median survival of 4 to 6 months in patients who present with advanced heart failure. In variant cardiac amyloidosis, the prognosis really depends on the mutation and the stage of diagnosis, with a median survival anywhere from 3 years to up to 12 years. So wild type, the cause of wild type TTR is really unknown. We think it's related to the aging process. The cause of variant TTR is due to a single amino acid mutation in the TTR gene. And there are over 140 known pathogenic TTR mutations, which results in variable phenotypic presentations. This slide outlines the genotype and phenotype presentations of variant ATTR. You can see here that some have a predominant neuropathic phenotype, some have a predominant cardiac phenotype, and then some have a mixed phenotype. V142I, also known as V122I, typically presents with a predominant cardiac phenotype. This genetic mutation is present in about 3.5% of Black Americans, but it has unknown penetrance. V30M can be either early onset or late onset. Early onset is endemic in regions of Portugal, where these patients present with a quite debilitating polyneuropathy as early as their 20s. Late onset V30M is more a mixed phenotype and is endemic to regions of Sweden and Japan. And then T60A or T80A it originates from the northern part of the Republic of Ireland, with about 1% of patients having this T60A mutation. So this slide just outlines what I've just mentioned to you. What about the prevalence of ATTR cardiomyopathy? Well, there's been several studies and reports regarding the prevalence. One report from Europe stated that 13% of patients over the age of 60 who were hospitalized with HFpEF and decompensated heart failure with an LV wall thickness greater than 12 millimeters were diagnosed with ATTR cardiomyopathy. It was found in 16% of patients with severe calcific aortic stenosis undergoing TAVR, and this was from Adam Castagno's work. It has also been reported in up to 5% among patients who have a presumed diagnosis of hypertrophic cardiomyopathy. And TTR amyloid deposits are found on autopsy in over 30% of HFpEF patients who are greater than 75 years of age. But I want to stress that this is amyloid deposits and it's not amyloidosis disease. Amyloidosis, as I've mentioned a couple of times now, is truly a multi-system disease. And what I really want to draw your attention to here is this bottom picture showing periorbital purpura. If you see periorbital purpura in your patient or macroglossia or both, you really have to consider a diagnosis of light chain amyloidosis, which, as I've mentioned, if missed, can be fatal quite quickly. So now moving on to the cardiac manifestations of amyloidosis. So in both AL and TTR cardiac amyloid, large deposits of amyloid, there are large deposits in the extracellular space of the myocardium, and this leads to a loss of normal tissue architecture and function. You have progressive biventricular wall thickening, as you see here on the bottom of the slide. This leads to biventricular increased stiffness without this compensatory ventricular dilation that we typically see in other non-ischemic cardiomyopathies. So these patients develop a restrictive myopathy, resulting in low cardiac output. In cardiac amyloidosis, the mechanisms of organ dysfunction are likely multifactorial, and they result from a combination of factors, including this extracellular deposition of amyloid that I've mentioned, which leads to mechanical disruption of the tissue structure, as well as proteotoxicity of the fibrils or the prefibrillar proteins that are deposited, leading to inflammation, reactive oxygen species generation, apoptosis, and autophagy. And this can be observed even before fibril deposition. So it leads to a restrictive physiology, as I've mentioned, diastolic dysfunction, and this eventually manifests clinically as heart failure. The direct toxic effects of circulating light chains in AL, cardiac amyloidosis, has been postulated to explain the discrepancies that we see between myocardial amyloid fibril burden, so between TTR and AL amyloidosis. The AL cardiac amyloidosis get much sicker much more quickly, and they have, as I've mentioned, a worse prognosis. And we think it is because of these direct toxic effects of the light chains causes this more aggressive disease trajectory. So the restrictive physiology that we see in these patients does require a tailored approach to heart failure management. They have restrictive function, they have very stiff ventricles, right and left ventricles, and this leads to decreased compliance. These patients, because they don't have ventricular dilation, they have a very fixed stroke volume. And as such, their cardiac output is very much dependent on heart rate. So the lower the heart rate, the lower the cardiac output for these patients. This also leads to preload dependence and afterload intolerance. So there's a very delicate balance between relieving congestion in these patients, yet maintaining a high enough filling pressure to maintain the cardiac output. So if you drop the heart rate too low, it decreases the cardiac output. But also if the heart rate is too high in, for example, atrial fibrillation, it affects the cardiac output by not giving them enough filling time. These patients, as a result, are very prone to organ hypoperfusion, and this often manifests as acute kidney injury. And Dr. Peretti is going to discuss treatment of these in the next talk. So conduction disease in these patients is common, and the spectrum of arrhythmias spans from both bradyarrhythmias to atrial, ventricular, and ventricular tachyarrhythmias. The mechanism of atrial arrhythmias is really multifactorial. We have fibril deposition in the atria. We have infiltration, as I've mentioned, throughout the atria and ventricles with impaired relaxation and restrictive filling. Elevated filling pressures in the atria result in atrial dilation, which of course makes atrial arrhythmias worse. And atrial amyloid deposition leads to myocardial fibrosis and remodeling, so thus affecting the biatrial filling. Amyloid, the prevalence of atrial fibrillation in patients with amyloid is about 50 to 70%, and it depends on the cardiac amyloid subtype. It is most common in patients with wild type, more common than AL or variant ATTR. And AFib is the most commonly encountered sustained arrhythmia in ATTR cardiac amyloidosis. Despite therapeutic anticoagulation, up to 33% of these patients may develop left atrial appendage thrombus, and that's why it's so important to perform transesophageal echo prior to considering cardioversion in these people, even if they are on therapeutic anticoagulation. So how do we treat them? Well, very basically, rate versus rhythm control. Rate control is challenging, as I've mentioned, because of this narrow heart rate window to optimize hemodynamics. Again, too slow is bad and too fast is bad with their relatively fixed stroke volume. So they need a faster heart rate to maintain adequate cardiac output, but not too fast. What about rhythm control? Well, it's particularly effective for earlier stage of disease at diagnosis. There is no survival benefit for rhythm versus rate control. And this was shown in a non-randomized study of wild type patients. 32% of the patients underwent rhythm control, mainly with amiodarone, excuse me, and the remainder underwent rate control. There was no difference in survival seen between these two groups. TEE-guided cardioversion is reasonable to consider, but it must be noted that the 1 year recurrence risk is high in these patients, up to 70 to 80% reported, depending on what studies are cited. And AFib ablation can be performed. The outcome of this is also controversial. What about bradyarrhythmias and ventricular tachycardia? So conduction disease is common. Standard indications for pacing are recommended. And for those who meet criteria for pacing, the use of a biventricular pacer can be considered, but the benefits of this are uncertain. Prophylactic pacing has also been studied and has not been shown to improve outcomes. Non-sustained ventricular tachycardia is very common in this patient population. And in this study here on the right, patients with ATTR cardiomyopathy and a control group who were age matched had remote monitors placed for 2 weeks. They were sent home. In 38 of these patients, so almost 82% of the patients with ATTR cardiomyopathy had non-sustained VT detected. And this is highlighted here in the orange. You can see The patients are lined up here on the left, and you have at the top the type of arrhythmia, so atrial fib or flutter, non-sustained VT, and so on. And you can see that in the ATTR cardiomyopathy group, there is significantly more arrhythmia detected on the remote patch monitors. However, the association of non-sustained VT detection on these remote monitors with sudden cardiac death is very unclear. And what about ICD, defibrillator placement? Not well supported by expert guidelines. So sudden cardiac death and cardiac amyloidosis is thought to be secondary to primarily to electromechanical dissociation, so PEA arrest. Not saying that VT arrest can't occur, but generally it's more thought to be PEA. Some studies suggest that in patients who receive an ICD, who appropriately receive one, the defibrillation threshold required for the amyloid-laden heart is much higher. And these patients may actually be refractory to ICD therapy when the time comes. In the patients who receive ICD therapy, if they have advanced heart failure, they still have a very poor prognosis. There have been no studies that show survival benefit in these patients. However, prospective studies are lacking. Now, moving on to the nervous system. So, neuropathies are pretty common depending on the subtype of amyloidosis that patients have. For individuals in endemic areas of Portugal with this early onset V50M or V30M, greater than 80% develop this devastating peripheral neuropathy. Patients with V142I variant, which is again predominantly associated with the cardiomyopathy phenotype, polyneuropathy is found in about 10%. And there have been various reports in wild type about the prevalence of polyneuropathy. Reports of up to 30% of patients may have polyneuropathy, but it's very controversial whether or not this is associated with wild type amyloid deposition. How does it happen? Well, the amyloid deposits in nerves, it's very unevenly distributed. The small or unmyelinated fibers are selectively targeted, particularly at first. And as this amyloid accumulates, it causes damage by various mechanisms: mechanical compression, which is what we see in carpal tunnel syndrome, direct blood vessel invasion, and then likely also, again, direct toxic effects of amyloid fibrils. So the types of neuropathies that we see focal neuropathies, again, like carpal tunnel syndrome. We see sensory motor polyneuropathies, initially affecting the small fibers. You'll typically see it affecting the distal extremities, so the feet and the hands first, and then larger fibers start to be affected. And then autonomic dysfunction or autonomic neuropathy, which is really quite debilitating. You see here on the right, autonomic dysfunction can really have a myriad of effects. The one we're going to focus on is orthostatic hypotension, but it can cause GU damage, so urinary retention, erectile dysfunction. You get gastrointestinal dysmotility, so patients suffer from diarrhea, constipation, gastroparesis. And in autonomic dysfunction, these patients will often, when they present with orthostatic hypotension, they're often going to tell you they feel dizzy, they feel lightheaded, they might feel pre-syncopal, their blood pressure may drop suddenly. And these are all things to be looking out for in your patients. Very non-specific, but again, signals of amyloidosis. So early recognition is essential in these patients, and it is very important that you have a high clinical suspicion and that early diagnosis is pursued. The presentation, as I've shown you, is very heterogeneous, it's very nonspecific, and it often mimics that of other more common age-related cardiac conditions and extracardiac conditions. And with a median survival of 6 months in advanced AL cardiac amyloid, and as I've shown you, 2 to 6 years in TTR cardiac amyloidosis, in the absence of disease-targeted therapies, of course, we do really need to rapidly diagnose and get these people on targeted therapy. At this point in time, we still see that delayed diagnosis or misdiagnosis is not uncommon. There was a survey of over 500 patients with AL amyloidosis, and these patients reported that they had seen over 5 physicians prior to their diagnosis being made. And in patients with TTR amyloidosis, they reported that rates of misdiagnosis were anywhere from 30 to 57%. So still very concerning. Around 80% of patients with ATTR cardiomyopathy have preceding orthopedic interventions, so even hip and knee replacements you have to be on the lookout for, and these can present up to 10 years prior to cardiac symptom development. TTR deposition in the ligamentum flavum in patients undergoing lumbar spine stenosis surgery is reported in a third of patients. And spontaneous biceps tendon rupture can occur about 5 years prior to heart failure diagnosis, and carpal tunnel syndrome anywhere from 5 to 10 years prior to diagnosis. This figure here again highlights the importance of high clinical suspicion and early diagnosis. This figure outlines development from preclinical stage to end stage heart failure. And these patients have initially just dyspnea on exertion, symptom, non-specific symptom of heart failure, among other things, in addition to arrhythmias. And then as they progress to this low output state. So as you can see in the preclinical and early clinical stage down the bottom, they have multiple therapies which are available to them and which may help their longevity. Whereas if they are not diagnosed until they are in end stage heart failure, therapeutic options are very limited, and only a select few can undergo heart transplantation. And finally, then, I just want to again highlight on this figure here how early recognition is just essential. You can see here myocardial inflammation or myocardial infiltration by TTR amyloidosis is very low at first in patients who have subclinical disease or who are NYHA class 1, and they have preserved functional status, preserved EF, preserved renal function, and really very low cardiac biomarkers. And then as the disease progresses and as myocardial infiltration increases in the heart, their symptoms progress, their disease stage progress. More importantly, their functional status declines, their ejection fraction declines, and their renal function declines. And at the same time, you'll see cardiac biomarkers start to increase and hospitalizations start to increase. So the ideal emerging therapeutic window is right here before they reach NYHA stage 4 or NAC or Mayo stage 3. You want to get them on treatment, and you want to get them on treatment in this stage before they have potentially irreversible declines in functional capacity. So the therapies then that we need to start or be thinking about in this therapeutic window, Dr. Pieretti is going to discuss in the next section, but they need to be started early in order to really to avoid this progressive end-stage heart failure. So I hope I have provided an understanding of the pathophysiology of disease, the heterogeneity of presentation, and the importance of early detection. And with that, I will end. Thank you.
Thank you, Dr. Griffin. As a reminder to all, these wonderful educational slides from all of our speakers will be available in the coming weeks on heart.org. Next with that, we welcome Dr. Janice Pieretti, who will be providing us with a deep dive into diagnostic pathways and treatment strategies. The floor is yours, Dr. Pieretti.
Good afternoon. Happy to be here. So Dr. Griffin did a wonderful job covering the clinical manifestations of cardiac amyloidosis. I'm going to delve into what you can see on imaging to assist your diagnosis of cardiac amyloid, and also treatment and the ongoing developments in new therapies. So to start for the echocardiogram, we're taught, the LV wall is thick, but when you're looking at an echo image in a cardiac amyloid patient, basically everything is thick: the right ventricular wall, the valve leaflets, the atrial septum. You can have a sparkling or speckled appearance of the myocardium. This is not as specific due to our modern imaging techniques. Notably, patients will have a small left ventricular cavity with a low ventricular volume, a low stroke volume, and there'll be varying degrees of diastolic dysfunction, as already mentioned. It can be mild to restrictive in more advanced disease. On echo images, you will also see dilated atria. Patients can have atrial thrombi, not only visible in the left atrial appendage on TEE, but you can see it in the right atrium as well. Pleural and pericardial effusions, and decreased global longitudinal strain, and an apical sparing pattern on LV strain imaging. So this is an example of decreased global longitudinal strain. This is the characteristic apical sparing pattern in the LV apex. And this has a pretty high sensitivity and specificity to distinguish amyloid from other etiologies of LVH. And as already mentioned by Dr. Griffin, there's up to, I would say 15–16% of patients who are presenting for TAVR evaluation have underlying wild-type cardiomyopathy. So these are the patients presenting, later in life with low flow, low gradient aortic stenosis. And this is just kind of a very kind of dramatic example. This is a patient with TTR variant CM. You can see thickening of the LV wall, the right ventricular wall, the atrial septum, dilated atria, and a pericardial effusion. On the right side, you can see that bullseye pattern where the strain imaging is preserved at the apex, and as you go out, it's decreased. On the EKG, the classic, things that we're taught is low voltage in the limb leads. This is variable. It's more commonly seen in patients with light chain amyloidosis. It really depends on the extent and duration of disease. And the most important thing to look at is really the voltage to mass ratio. So whether what you're seeing on the EKG matches what you're seeing on the echocardiogram. Notably, there are some AI tools now being developed to screen EKG findings and possibly lead to early detection of cardiac amyloidosis. Other things that we see are infarct patterns, as already mentioned, conduction disease. It can be first-degree AV block, interventricular block, vesicular blocks, atrial arrhythmias, as mentioned. Patients can also have poor heart rate variability on monitors, indicative of chronotropic incompetence. This is an example of a patient with ATTR-CM. You can see that there's low voltage in the limb leads, and you can see that infarct pattern in the anterior lateral leads. On MRI, so in patients with amyloidosis, the interstitial expansion of amyloid deposits avidly picks up and retains gadolinium. So you see a pattern of global transmural or diffuse subendocardial LGE. This pattern of LGE has a high sensitivity and specificity for cardiac amyloidosis. In addition, you might see on reports this thing called difficulty nulling the myocardium. This is highly sensitive for cardiac amyloidosis. So basically, this is an operator determined null point where the inversion recovery time makes the myocardium, which should appear black or null. And again, if you see this is pretty highly sensitive for cardiac amyloid. Additionally, T1 and ECV measurements have been very helpful as well in diagnosing in patients with cardiac amyloid. So T1 mapping is a way of measuring fibrosis. This is markedly elevated in patients with cardiac amyloidosis. And ECV measurement, increased extracellular volume, is markedly increased as well. So if we see something on an MRI where the ECV measurement is greater than or equal to 40%, that can very much confirm cardiac involvement with amyloid deposition. 30–39% can indicate early infiltration, and less than 30%, it's less likely to be cardiac amyloidosis. So now you've seen a patient who has all the clinical features that Dr. Griffin reviewed, some of the echo EKG findings. And so what do you do? So the first thing is to rule out AL. And you just have to do these 3 tests. One is a serum kappa and lambda free light chain quantification with ratio. The other is an SPEP, or serum protein electrophoresis with immunofixation, and a urine protein electrophoresis, which should be a 24-hour collection, again with immunofixation. So why immunofixation? So SPEP and UPEP only tells us how much of a monoclonal protein is present. Immunofixation is much more sensitive and specific and can tell us the type of monoclonal protein that's present. So it's specific against kappa and lambda. You can certainly have a positive immunofixation finding with a negative electrophoresis. So it's always important to include that in your diagnostic testing. If the AL screen is abnormal, then you're left with the differential of whether this is a monoclonal gammopathy of undetermined significance, which really is a diagnosis of exclusion when you're evaluating a patient for cardiac amyloidosis. The other possibilities could be multiple myeloma or light chain amyloidosis. So, what makes things a little bit difficult is that in our aging population, the prevalence of a monoclonal gammopathy increases. So, up to 40% of patients with ATTR-CM will also have a monoclonal gammopathy. But again, it's a diagnosis of exclusion. So, at that point, the recommendation is to do an endomyocardial biopsy and refer to hematology oncology. On biopsy, the first part is a Congo red stain. This identifies amyloid fibrils. And the next important part is mass spectrometry. This actually identifies the protein. It can identify whether it's a light chain versus transthyretin. It can tell you if it's a kappa or lambda. And if transthyretin is present, gene sequencing is done to differentiate between wild type and variant. Just a note on fat-pad aspirates. Fat-pad aspirate is a small sample size of adipose tissue from the abdominal wall. You can do Congo red staining, but you don't have enough tissue to do protein ID. If it's negative, you're not really done. It's only helpful when positive. You know, up to 45% of patients have a positive fat pad aspirates who have TTR amyloidosis. That's a bit higher, 84% in patients with light chain amyloidosis. A fat pad biopsy, on the other hand, is a larger amount of tissue. And on that, you can do Congo red staining and mass spectrometry for protein identification. So, if you've done your monoclonal gammopathy screening with those three tests that we reviewed, and all of those three tests are normal, then you can go ahead and do radionuclide scintigraphy. And if you do this and it's positive, you can be very assured with your diagnosis of ATTR-CM. So this has a positive predictive value of 100% for ATTR with a grade 2 or 3 uptake. And, this is the caveat, absence of a monoclonal protein in the serum and urine. So this is a really kind of revolutionized the way that we diagnose cardiac amyloidosis. We can avoid endomyocardial biopsies. These are use bone avid radiotracers, whether it's PYP or DPD or HMDP. And again, high sensitivity for detecting TTR, even in subclinical or early phase of disease. Important to note that patients with light chain amyloidosis can have a positive scan. So that's why it's important to do your screening in the appropriate manner. Now moving on to ATTR-CM treatment. So there's two arms. One is to manage heart failure symptoms, and the other is to treat the underlying pathology with disease-modifying therapies. So Dr. Griffin already covered this in a bit, but really the management of heart failure symptoms, the mainstay is really management of congestion. So careful titration of diuretics, as already mentioned, is important. Loop diuretics are commonly used. Torsemide and bumetanide are preferred if there's bowel edema. You can use spironolactone as a potassium sparing effect. We have some subgroup analysis in the TOPCAT trial that shows that there might be some benefit in patients who had echo features of cardiac amyloidosis and may have had some reduced adverse clinical outcomes. And also sequential nephron blockade can be used if you need to with metolazone. In terms of other therapies that we're used to seeing for heart failure with reduced ejection fraction, we have to be cautious, as already mentioned, in patients with cardiac amyloidosis. Beta blockers can worsen symptoms because you're decreasing the heart rate. So decreasing a patient with pretty restrictive physiology from a heart rate of 80 to 60, for example, can really reduce their cardiac output due to their fixed stroke volume. And then ACEs, ARBs, ARNIs, nitrates can be very, as well, poorly tolerated in patients who have already low resting blood pressures and maybe some degree of dysautonomia. Digoxin and non-dihydropyridine calcium channel blockers are, kind of avoided because they can bind avidly to amyloid fibrils, and we can have potentiation of those negative effects of those drugs. And SGLT2s can certainly help relieve congestion. More studies are needed to determine whether there is a benefit for hospitalizations or or cardiovascular mortality. There's some single center observational studies that shows that there's a signal that this may be beneficial, but again, more studies are needed, and definitely can use this to help with congestion. And management of arrhythmia and conduction disease was nicely already reviewed by Dr. Griffin. Basically, this is kind of summarizing the same points that she has already mentioned. One of the things, with device therapy, pacemakers, of course, are very beneficial for patients who have conduction disease. And then a note about ICDs, it's a very controversial um, area that we don't have clear guidance yet. But I would say that an ICD could be, considered, of course, in someone who has documented aborted sudden cardiac death with a greater than 1 year survival. If someone has significant ventricular arrhythmias, and the definition of significant ventricular arrhythmias is also kind of a gray area because patients have runs of non-sustained VT on Holter monitoring who have cardiac amyloidosis. And then, some, electrophysiology teams are considering doing an MRI to assess the extent of fibrosis, considering an electrophysiology study. And also, we're using implantable loop recorders for added surveillance. So, moving on to TTR-directed therapy. So we've really come a long way in treating ATTR-CM. So based on this slide, there are drugs that are targeting kind of every step of the way of the mechanism of TTR, cardiac amyloid, from TTR synthesis to amyloid fibrillar deposition. So on the left side, these are the gene silencers, eplontersen and vutrisiran. These are drugs that go into the nucleus of the liver cells and stop the cells from making the DNA. So you decrease TTR production. In the middle is TTR stabilizer drugs, acoramidis and tafamidis. These are both drugs that can bind to the TTR tetramer and kind of hold it together so it doesn't unravel and form an amyloid fibril. And on the right is kind of the new area of research looking at ways to actually remove amyloid fibrils and possibly reverse a cardiomyopathy. So this is a summary slide just looking over the two stabilizers that are currently FDA approved for ATTR-CM. So tafamidis was the first drug that was approved for the treatment of ATTR-CM back in 2019. It was a landmark study which showed a significant reduction in death and cardiovascular hospitalizations in patients on tafamidis versus placebo. Very notably in this study, patients who had a lower functional class had a greater degree of benefit, which makes sense because we're slowing progression again, and unfortunately not able to reverse kind of the damage that's been done. The second stabilizer is acoramidis. It was approved in 2024. This confirms a nearly complete stabilization of the TTR tetramer. Again, very good data for having benefits in outcomes of death, cardiovascular hospitalizations, functional capacity, and it has a significant sustained and early stabilization in TTR. Moving on to vutrisiran. This is the currently the only FDA-approved gene silencer for ATTR-CM. It's been approved since 2022 for patients with ATTR variant polyneuropathy, but more recently approved for ATTR-CM. Some of these patients were on tafamidis at baseline, Some were on monotherapy, some added tafamidis after randomization. But regardless, there was a serum TTR reduction about 80% and a benefit in all-cause mortality and recurrent cardiovascular events in the overall population. Unfortunately, this study was not powered to compare vutrisiran monotherapy with combination therapy. So now you have options. You've made your diagnosis and you have all of these options. What do you do? So there is no comparative evidence available yet to ascertain superiority between stabilizers and silencers. If you have a patient with a mixed phenotype who has polyneuropathy and cardiomyopathy, silencers are recommended as first line, as there is more data with effects on neurologic progression with use in gene silencers. Otherwise, consider the cost to the patient, their insurance coverage, the patient preference, whether they want to take an oral tablet versus a subcutaneous injection. And again, there's still no evidence in supporting combination therapy or switching from class to another if you have progression of symptoms. So what's on the horizon? So the path forward for ATTR-CM is further development of gene silencing drugs, so looking at decreasing dosing frequency, achieving higher TTR knockdown, also permanent TTR knockdown with gene editing. Do we really need transthyretin? Probably not. And also can reverse cardiomyopathy with fibrodepleters and also prevent disease onset in patients who are known carriers. There's also studies using different imaging modalities to improve detection, progression, and response to therapy. So just briefly to go over what's new trials that are being completed or actively enrolling. So this is a cardio TTR transform trial. It is looking at a gene silencer called eplontersen, and it's a randomized trial with wild-type and variant TTR patients. It's a very large trial, the largest to date of patients with ATTR-CM, 1,400 patients. It's looking at all-cause mortality, cardiovascular hospitalizations. Patients are allowed to be on stabilizer therapy. So we're hoping that we'll have a little bit more insight on combination versus monotherapy from this trial. Nucresiran is just the next generation of vutrisiran. It's a gene silencer that is given every 6 months, as opposed to every monthly or every 3 months. And this is actively enrolling. And then NTLA 2001 is CRISPR gene editing. So this is also very exciting technology and promising therapy for ATTR-CM. So basically, CRISPR gene editing kind of permanently reduces your TTR production. NTLA 2001 is an IV infusion. So there's something called Cas9 messenger RNA and a guide RNA that are packaged into this lipid nanoparticle. The liver takes up the nanoparticle through LDL receptors and releases this RNA cargo. The Cas9 messenger RNA makes an enzyme which pairs with the guide RNA, and basically what it does, it cuts into the TTR DNA and makes precision cuts throughout the genetic sequence. The cell's response to this is to try to repair it and makes a series of insertions and deletions that basically renders the TTR non-functional. So there's been, phase 1 studies showing that there is a 90% durable TTR reduction with a single dose. There's a current phase 3 trial that's randomized, double-blind with wild-type and variant. Again, looking at primary endpoints of mortality and recurring cardiovascular events. And then just to touch base on depleter therapies. So this is a case series from the National Amyloidosis Center in the UK that described patients who had kind of endogenous antibodies against ATTR-CM. And what they saw is that patients had a clinical improvement over time. Basically, these naturally kind of produced antibodies were able to work to reduce the amyloid burden, and they could see regression on MRI imaging and nuclear scintigraphy imaging. So we're hoping to be able to replicate that with monoclonal antibody depleters. This is one of them, ALXN 2020 2220. So the way that this works is that it binds to the amyloid fibrils and pretty much triggers your body's own macrophages to promote fibrillar clearance. There's been phase 1 and phase 2 trials with this that were promising. They noted a reduction in extracellular volume, a trend toward lowered NT-proBNP levels, and there's a phase 3 trial now ongoing, actually that already completed its enrollment, and we're awaiting those results. This is another monoclonal antibody, PRX004 or coramitug. Again, kind of the same concept where it promotes immune-mediated clearance. There's phase 1 and phase 2 trials that look promising, and there's a current phase 3 trial that's enrolling patients. And to take it a step further, can we prevent the development of ATTR-CM? So ACT Early is a trial using acoramidis, and the population here are asymptomatic carriers of pathogenic TTR variant, and where they're starting acoramidis can prevent or extend development of ATTR-CM. So this is an event-driven prevention study with a long follow-up. So how are our ATTR-CM patients doing? So Dr. Griffin showed you a slide, kind of the natural history of our patients with ATTR-CM and their overall, years of median survival. This is a slide by Dr. Gerard and Sperry. This is not to compare, survival probabilities between patients these different trials. The point of this slide is to show that with time and which each iteration of these ATTR-CM trials, that overall survival in the patients that have been, observed is increasing, and it's approaching age expected mortality. So this is very promising that patients are not, having to die from a cardiac amyloidosis, but can be a disease that they can live with and that can be managed. So key points to remember: look for it in your clinical history, echo, EKG, MRI. Treat early for best outcomes. There's very, very good TTR-directed therapy and also ongoing development of novel therapeutics. Thank you for your time.
Thank you, Dr. Peretti, for that extensive overview. I would like to now welcome Dr. Eugene Brailovsky, who will be guiding us through multidisciplinary collaboration in managing cardiac amyloidosis. Welcome, Dr. Brailovsky.
Thank you so much. It's great to be here. Thank you so much for hosting this webinar, for highlighting the need to improve education and awareness of the disease. So I'll quickly run through, with not a lot of time left over, just to highlight some of the key features of the team and what's important and how we can move this field forward. So as you heard, it's a rapidly evolving field, increasing disease awareness, increasing diagnostic capabilities, and most importantly, increased disease targeting therapeutics. So as you heard, again, this is a systemic disease with a lot of systemic manifestations. So you need a lot of friends to kind of help diagnose these patients and treat them, more importantly, symptomatically. They have a lot of extra cardiac manifestations. So it's important to have renal colleagues and neurologists and GI docs and neurologists to kind of help manage these patients. And more so, some of these patients will come in to your colleagues first and get diagnosed with various extra cardiac features. So that's another avenue to pick up patients and diagnose them much earlier than the cardiac manifestations. And we're probably seeing just the tip of the iceberg, so to speak, of when we're just talking about heart failure. This is a nice slide from Dr. Griffin's paper from a few years ago, highlighting that we're probably just seeing heart failure patients as the last stage of their disease, but they have a lot of extra cardiac manifestations that occur much earlier, and we can pick up a lot more patients early in the disease course if we look for these features. And as you heard, there's many different mimickers, so to speak, of TTR amyloid, which is the focus of this talk. But the AL patients and other amyloid patients will come in with similar features, but will be very different pathophysiology, and treatment is very different. So it's important to have a team around you that can help you figure out which type of amyloid specifically the patient have before we start treating them. And again, as you heard from Dr. Griffin first, that AL and TTR can look very similar, but have a very, very different pathophysiology and very different therapeutics. And their management is also very different because their prognosis will be vastly different between AL patient and TTR. And it's important to diagnose them, and you cannot do it in isolation most of the time. And there's a nuanced interpretation of the testing. As you heard, we rule out AL with multiple labs, and we want to diagnose TTR with mostly non-invasive approach with PYP imaging, for example. But there's a nuance how you interpret these the diagnostic tests. As an example, the light chains will be abnormal in patients with renal disease, and you have to adjust for the GFR in order to not over-test your patients and not and none of them, most of them don't have to have a biopsy to diagnose them if you take that into account. Similarly, it's important to know if you're biopsying other organs, what the sensitivity and specificity of those things are. And as you heard, there's been a tremendous progress in therapeutic arena for TTR, but most of these are very, very costly, and this is where specialty pharmacy becomes a very important member of the team to help you navigate the cost of these therapies, how to get them approved, and how to get patients other financial assistance. And similarly, in patients with AL, there's been a tremendous progress in therapeutic arena, and the drugs are becoming more and more specific and less toxic and more potent. And it feels like from talking to AL colleagues on a daily basis, every week they come up with a new name that I can't pronounce. So it's important to keep up with those strategies and figure out how we can get our patients better. And again, that takes a team approach. And that team usually consists of multiple specialists. Everybody will be slightly different from hospital to hospital, but these are kind of the major team members. The cardiology and hematology, oncology, neurology, like I said, specialty pharmacy, all play a key role in these teams. And there's a concept of amyloidosis centers of excellence, and it's not a term that's used with any kind of guidance, so to speak, but a lot of the centers will give themselves that the identification. But there's probably some minimum requirements that teams should have to call themselves that. So it's rapid delivery of care, rapid diagnosis, availability of therapeutics, both for TTR and AL, heart transplant availability or stem cell transplant capabilities, and then availability of educational resources, patient support, and partnering with community. And there's probably some minimum requirements in terms of diagnostics, as you heard from Dr. Griffin's talk. So this is from a survey from a few years ago, from where they surveyed a bunch of centers to try to get a consensus of what the minimal requirements for these patients. So most people agree that at least these are minimal requirements. So echo, Congo red staining, I'm not going to go through all of them, but the only thing that kind of probably is not required on site is MES SPECT, which is only done in very few centers around the country. And there's probably some minimum requirements agreed upon with different team members that should be involved. So again, that's hematology, oncology, neurology, cardiology as the main players. But it's also important to consider pathology, to interpret those pathological specimens. Genetic counselor is probably not a must, but very, very helpful. Although I would argue in the patients with autosomal dominant disease, that is probably less important, but still would be very helpful. And again, having multiple team members across the spectrum is important as well, from nurse practitioners to nurses, nursing coordinators, makes the care of these patients very smooth and carefree. And then from this paper, they came up with different designations. I'm not going to go through everything, but a lot of people put a lot of thought into this of naming different centers from bronze to silver to gold to figure out how we can deliver the care better. And to briefly chat about specialty pharmacy and what they do and what they mean, especially if they have a 340B program. For those of us who don't know what that means, so 340B is a government program that mandates that the big companies sell the therapeutics to a specialty pharmacy at a discount cost if the specialty pharmacy is located in underserved areas. With the idea is that then those specialty pharmacy and hospitals can translate those cost savings to patients by providing grant support and other resources to underserved areas so that most patients can get on therapy quickly and most patients can get on therapy with minimal cost to them because those costs are real and toxicity of costs is very real and can make the patient pretty bankrupt pretty quickly if that's not taken into account. So again, some of the resources they can provide, they take care of prior authorizations, they provide financial assistance, ship medication directly to patient, and therefore increasing patient compliance. So again, how do you do this? How do you partner with the community? So if you divide your centers into various categories, so to speak, so there's amyloidosis partnering centers where most of the patients that we see are probably not going to be identified by centers of excellence, so to speak, but they can be identified in the community. And there's various way of doing it, either through clinical exam or through EMR review or through implementation of artificial intelligence tools to identify patients and then refer them for further testing and workup and treatment. And that comes to establish diagnosis, initiate therapeutics at the amyloidosis clinic, where you can diagnose patients with the tools that that you heard about, where you can provide specialty pharmacy support and then identify patients who can be eligible for clinical trials and then refer them for advanced therapies. And those advanced therapies could be delivered in kind of centers of excellence where they see more advanced cases, but also provide advanced therapeutics and clinical trials. But it's important to partner across all three of those layers to make sure that you're not just delivering care at one center across multiple states, but you can deliver care at multiple sites and also provide kind of a shared care model where you can see patients locally and then rely on expert centers to provide more expertise and then more advanced therapies. And I went through everything pretty quickly, but I'm sure that we can provide resources and we can open up the floor for more questions. Thank you so much for hosting again.
Thank you, Dr. Brailovsky. And yes, we know we are very much at the top of the hour and over time. If anyone on the call has any questions, please feel free to either submit those in the chat or you can submit those via email, and we will be sure to answer them following the call as the recording is posted and the resources are available. So as we wrap up, we invite you to stay connected. I apologize, we are out of time for the Q&A and want to be respectful of everyone's time. But please stay connected with us through our website, www.heart.org/ATTR-CM. You can scan the QR code there to go to the website or connect with us via email at clinicalstudies@heart.org. I would like to extend an additional or a final thank you to Dr. Griffin, Dr. Peretti, and Dr. Brailovsky for their leadership on today's call and their time and their leadership in this field. Thank you again, everyone.